I'll be with you in a few minutes. I'm setting up.
I can't get you.
Just a minute. If everybody wants to come in the panel, hold on.
Sorry, I didn't get you.
Yeah, if you're in the panel, I'm gonna get the feedback off here. Hold on. All right. Hello. Hello.
Yes, I can get you now.
Yeah. Well. It's not there. Not there. Oh, Sean. Okay, I'm stopping.
Okay.
Loop testing. Oh, yeah. Testing 1, 2. Testing 1, 2. Wow. Okay. Okay, that's better. Okay. Very can you hear me okay?
Yes, I can get you now.
Okay. Trying to get the sound. Maybe,
Sorry.
okay. Yeah, maybe it's okay. Do you hear an echo?
It's clear now. I can get you.
Do you hear an echo?
No, it's clear. I can get you.
Okay.
Yeah.
Hey, John.
Hey, how you doing, Well?
Good, man.
There's,
You know what?
the sun, there's no echo, right?
No, no, it's pretty good. No,
Okay,
I can.
okay.
Yeah.
Wasn't sure.
John, quickly. So I just got a message from Ebenezer Tercet and Nelsie as well. I see Nelsie promoted. How are you, Nels?
Hi,
Okay,
good
let me,
morning.
Good to see you now. Thanks so
Good.
much.
you can see the panelists, right?
I can. Can we escalate
Okay, tell me who I need to bring in here.
Ebenezer Tercet? I think he's part of the member, or
Can you see me?
Nezer. And then Basil Enica as well, please, John.
Okay, okay, to the panelists, anybody want to come in? Raise your hand.
Yeah, and then
Can try
Basil.
to share my
Okay, there we
screen.
go, Basil.
Everything is okay.
Basil, you're in, right? Anybody else, raise your hand. Okay, Basil, I'm asking you to come in. Okay, you're declining to come in. Mobile, if you want to come in, you gotta accept my invitation to come in the room. Otherwise, you cannot be in the panel. Majubil is in the panel, Llewellyn?
No.
Okay,
No.
any of the people there need
Yeah.
to be admitted?
No, so far we're good, John. I'll let you know as we.
Okay. Hagai, Saccone, I don't know if they're in.
No.
Okay, they're in, and if they're not coming in, I assume
Yeah.
that they're not panelists.
John, so Nelsie wanted to test the slides.
Okay, anybody else there? Okay, anybody in the panel that wants to come in, please raise your hand.
I need to be out and go in again. Just
No, you're there,
to
you're here,
adjust.
you're here.
Okay, try to see if it's sharing now.
Okay,
It's sharing or not?
yes. You want to
Okay.
put it on presentation mode?
Presentation mode.
There we
should be
go,
okay.
perfect.
It's okay. Fantastic.
Okay,
Thank you. I will stop sharing.
okay. Llewellyn, how you been?
I've been good, John. How you been? It's been a while
Alright.
since we did something together. I'm
Yeah, a
glad.
couple months, at least 3, 4 months.
Yeah. Just, John, quickly, can I ask you? So, Nels, lovely new frames, Nels. They suit you beautifully, by the way. Hey?
Thank you.
Baz, you want to test your slides as well? Basil, Annika, John. We'll introduce all of them just before, but Baz, can you hear me? You want to test your slides?
Yeah, usually pretty good at that. Sometimes I miss.
Okay, great. Good,
Go
Baz.
ahead,
Thanks.
you want to, Basil? There you go, perfect. You got it.
Okay, great. Good, Baz. Thanks, man.
Yeah, presentation mode. Do you know how to put that on, Basil? It's not on presentation mode yet.
Yeah, that's it.
No, there you go. That's the right place. Okay, you want to get off the screen share?
Okay. John, I'm also gonna have a quick try after Basil. I want to show just a few slides to start off. Okay, Baz, you're gonna stop sharing.
Oh, you want to start sharing?
Yeah, I just want to test mine as well. I've got about 5 or 6.
Yeah, go ahead. Okay, let me get this person off. Um, uh, oh, I'm gonna share. Yeah, go ahead.
Okay, should I go
Go
ahead?
ahead.
Okay.
Go ahead, Llewellyn.
Yep. There we go. There we go. Okay, John, is that good?
Yeah, good.
Okay. Yeah, perfect. Okay, great. So I'll stop. And then Ebenezer, you want to do a quick test as well of your slides? Ebenezer? Is he still on?
Yeah, is that okay?
Yeah, perfect.
Thank you.
Okay, John. Let me see if there's anybody else who we need to lift the names. Okay. Yeah, not yet, John. So we're still waiting for Teddy Totima, James Belogan, Mohammed Al Baltagi, and Tony Figaji. Okay, I'll look out for them, John. I'll let you know as soon as they come on.
Okay, so everyone's okay now?
I think we're all good so far, yeah.
Okay, anybody in the panel, raise your hand and help us. You know, Zoom used to allow you to have a co-host, but it doesn't do it anymore.
It's not that, okay. John, if we could elevate James Belogan, please.
Okay, once again.
James Belogan.
Okay, James. Okay. Okay. Got James. James, I'm sending you an invitation, James. Please come in. Graham Fegan.
Yep. I see Graham as well. Graham's there. So if you can, I don't know, I haven't asked him, but I think Graham would be okay with being escalated. Let's escalate him, please, John.
Now, James declined to be promoted.
He shouldn't. You send him a message.
James, to hear me, you have to accept my invitation to
Okay.
come on the panel if you want to present. Some people like to, okay, maybe he did come in. James, okay, James, come in. We're going to have a good crowd today.
Okay, great. Do you have any idea how many registrations you had, John? You normally have a number somewhere.
Not yet.
Yeah, okay.
Okay, anybody else in the panel want to come in?
Let me check again, John.
Just take a look at that list.
Okay, panelists. So we've got James, John, Harshad, Basil. Yeah. So it's still
Graham Fegan.
yeah, no, he says he's happy to just attend. Okay, so we'll wait for Mohammed and Teddy and Fagaji. Let me just check down quickly.
And we can start as we have the first presenter here.
Yep, we do. So
Yeah, we can start, and the other people just chat and say, John, please admit whoever.
Okay. Okay.
Mariachi. Hold on.
Let me just see if Mohammed joined as well, please, John. No, I don't see Mohammed there yet. Okay, Mohammed sent me a message, John. He says he's still stuck in the OR, but he'll join in a bit, so we can probably get started.
Okay, ready to start? Ready to start?
I think so, yeah.
Okay, here we go. Oh, we get a lot of people today. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is John Bennett of Neurosurgical TV. We have the honor of having Llewellyn Padayaki to help direct the AFPNS ISPN educational webinar from South Africa. I'll turn it over to Llewellyn to run the proceedings. Okay, welcome, Llewellyn.
John, thank you very much. I think you can hear me. I always struggle a bit with this unmuting. Thanks so much, John. So firstly, I'm doing this on behalf of the African Pediatric Neurosurgery Section. So myself, Mohammed Al-Baltaghi, Teddy Totimer, Ebenezer Tersit, James Belagon, and we've got some of our newer joinees as well, Basil Enika. So we're running this together with the ISPN. John, you'll see, is my slide showing?
Yeah, it's not full screen yet, not presentation mode yet.
Is it?
Not
Okay.
yet.
Let me do it again, John.
Not yet.
Let me do it
Gonna
again.
try again.
Yeah, that should be presentation mode now, right?
Not yet.
Really?
No.
Okay, John, I'm just going to run through it like this as long as you can see it. So, firstly,
Okay. Okay.
on behalf of our African Pediatric Neurosurgery Section, which really represents at the moment pediatric neurosurgery from Africa, and we run the series of webinars specifically to promote attendance of the ISPN meeting in Cairo. That's in October 7th to 11th. You can see the date. The Congress president for that is Mohammed Al-Baltaghi. So our first webinar series is themed or centralized on hydrocephalus and CSF disorders. Moderating this is myself and Mohammed. Our panelists are Tony Fagaji and James Belagan. Our speakers, we've got a fantastic panelist of speakers. We've got Nelson Zenon, who's a highly esteemed pediatric neurosurgeon from Sao Paulo, Brazil. Teddy Totimer from Accra, Ghana. Ebenezer Tersit from Addis Ababa in Ethiopia, and Basil Anika from Durban, South Africa. So we're going to cover quite a nice sort of overall perspective of hydrocephalus and its management in pediatric neurosurgery. You'll see our QR code here. Hopefully you can see that. Please scan that. That also gets you a quick link to a Google Doc that will help you to join in the AFPNS activities. Just quickly, some of our MOUs and collaborations. The AFPNS has grown beautifully over the last 2 years. So we've got MOUs with the ISPN, the American section, the ESPN, IFNE, SLN, PED, and CANS. It's just that we've got one pending with the Asian Society. So really, I think we've branched out beautifully with the section. Our most recent signing was with SLN PED. This is a nice little graphic that we used to symbolize the signing between the Latin Americans and ourselves. The team has grown beautifully now from originally these 5 to include French-speaking parts of Africa. And we've got over 100 members signed up now, and we're growing on a daily basis. So really beautiful growth. Some of the meetings we've had before, one in Addis Ababa, one in Accra, and one in Pretoria last year. John, with your help, we've run these webinars. We run 9 of them from 2022, and we're going to resuscitate that effort this year with the goal of building up African attendance at the ISPN meeting in Cairo. That's our website, www.afpns.org.
Excuse me, Llewellyn, it's not moving. The screen's not moving.
Isn't it? Okay. John, I'm happy to stop there. Anyway, so I just had one more slide to show. So I will then, John, go ahead and introduce our first speaker. So it was going to be Mohammed's role to do that. I think he's still a bit delayed, so I will introduce our first speaker. Let me see if he's joined, John. No, I said he will join a little later. Okay, John, can I go ahead and introduce our first speaker?
Sure.
Okay, so our first speaker, and we're really, really honored and privileged to have Nelsie Zenon, who agreed to give us a talk on pediatric hydrocephalus. So Nelsie is a highly esteemed pediatric neurosurgeon from Sao Paulo with tremendous experience, a very prominent member of the ISPN, the Latin American Society of Pediatric Neurosurgery, the Brazilian Society, previous education chair of the ISPN, has really made phenomenal contributions. So we're really honored to have Nelsie. And Nels, with that, I'm going to ask you to please share your screen and start your talk. Thanks, Nels.
Perfect. Okay, unmute, Nelsie. Oh, you went back.
Okay, thank you very much for
Well, hold
this.
on, you fell off your screen share.
Yes, thank you, John, for this help and fantastic job you are doing on Neurosurgical TV. We are proud to have your contribution. And thanks a lot, Padiashi, for this kind invitation. It's a privilege and honor as a ISPN secretary to participate on this very important webinar with the support of African Pediatric Neurosurgical Society and ISPN and CANS. I'm living in South America, Brazil, one of the 7th most populous countries in the world, and working in São Paulo, is a city where we have more than 12 million inhabitants in this urban area. In the last 2 years, I'm working in Santa Casa, is the oldest hospital in São Paulo, more than four centuries history, taking care of the helpless people, is a philanthropic institution. And no conflict of interest on this conference. And talk about neonatal hydrocephalus is not common to talk about prevention, but I think it's important to go further and try to understand how we can do to decrease this etiology for hydrocephalus before talking about treatment. How we can see here the 50% of etiology for hydrocephalus in neonatal and infants period is spina bifida and intraventricular hemorrhage associated to prematurity. We have already noticed that spina bifida, when we do fetal surgery, we decrease more than 50% hydrocephalus on this special group of patients. But we have prematurity associated with fetal intervention. And intraventricular hemorrhage is linked to the prematurity and responsible for 1/3 of this etiology. Is not my project, is project from Santa Casa. He started when he was resident, Gabriel Variani. He started to develop this neurocritical care, education, and promoting homogeneity of the care on these premature babies with telemedicine. The project name is Protecting Brain and Saving Lives, and start in 2016 in neonatal intensive care units. What the pillars for this monitoring is remote or multimodality monitoring, IAG, video EEG, NIRS, longitudinal education, real-time consulting, research. And we have this example here in the Santa Casa, but now present in more than 50 neonatal intensive care units from July 17 to May 2025, more than 50,000 monitored infants. The most important finding, I think, is 60% had diagnosed seizures, only electrographic, not clinical seizure. I think it's an important indicator to prevent intraventricular hemorrhage if you treat in real time with homogeneity of this care, and is this unit with the local monitoring, but the distance telementoring neurologists looking in, and with augmented reality, we can see also the local image. The result is quite impressive. Between 2021 and 2022, decreased mortality in half of these patients, and intraventricular hemorrhage more than 50% on the patients less than 1.5 kilograms. And the group of patients less than 28 weeks decrease also mortality and severe intraventricular hemorrhage in more than half of these cases. And even an economical question, this reduction on 10 days in the length of hospital stay on this group. Back to our hydrocephalus, is a large proportion of daily work for a pediatric neurosurgeon, for all of us. And here we have some topics, some tips and tricks, but you can find much more on the library. ISPN library is free registration, and you have much more lecture there, recording and available. Hydrocephalus is the global prevalence around 80 for 100,000 individuals, but it's very difficult to know exactly the numbers, because the incidence of malformations with the termination of gestation and the spontaneous abortions, these numbers is not in this number of statistic. And more, the pediatric neurosurgeons are in the counseling program for this antenatal counseling about hydrocephalus on every other spinal and brain malformation. If we consider that we are spiritual beings having an experience on earth, becoming easier to take care for these very difficult lives, and the family needs to take care for them for life. Maybe one difficult difference that we need to pay attention is the difference between ventriculomegaly versus hydrocephalus. It means we can have dilatation of the ventricles without clinical symptoms, and we need to pay attention to the clinical signs before treat and be sure that we are doing the right things. Just for discussion at the end of this webinar, last night by WhatsApp, the resident sent to me these two informations. This term baby with this dilatation of the lateral ventricles, the head circumference just above of the 97 percentile, but soft fontanelle. Do we need to treat? Wait and see. Ventricular subgaleal shunt, ETV+CPC, or VP shunt. Is always an imbalance between production, absorption, and circulation of the CSF producing hydrocephalus. And when we are looking for the symptoms or clinical manifestation, we can have rapid head circumference enlargement, bulging fontanelle, dilated scalp veins, setting sun sign, in later on bradycardia, apnea, irritability, and development delay. The question is what the real moment, the best moment that we can treat this patient with safety and prevent brain damage. Just a reminder that in this baby in neonatal period, hemoglobin just can drop out and we can find the diagnosis of intraventricular hemorrhage. What about image to do the diagnosis? We start with ultrasound, the feasibility and not necessity of transportation. The CT scan, we have the radiation, but time to time the availability is the only one. The MRI is precision but related to cost. And 90% of intraventricular hemorrhage occur in the first 3 days. It's important if we have a premature baby, try to start the day 1 or day 2 ultrasound, transfontanelar ultrasound to have the diagnosis early on. And when we talk with parents, try to translate to them something related to hydrocephalus, we tell them that is like a river, that we have some block in some way, and the flow of the water can go continuously like it was before. The obstruction can be partial, total, or can be hyperacute, progressive, chronic, or arrested. The term arrested can have some discussion if there is really arrested or in some moment in life can be a clinical manifestation. When we have edema, transsudation edema on the MRI, we call as an overflow. We need to do something quickly. And the hydrocephalus, the word for ardoricate, still until today, the treatment remains of the most difficult challenge faced by the neurosurgeon, not the technical issue, not the surgery, but the decision-making process. It means choose the best method for the treatment for this individual child on the right moment. And when we are talking about small baby, premature, and is even more complicated, our options is even less than the term infant. Medical treatment for hydrocephalus doesn't work, and even worse the result when we compare with nothing. And these 6 options, serial lumbar puncture, ventricular reservoir or access device, ventriculo-subgaleal shunts, external ventricular drainage, endoscopic third ventriculostomy with or without coagulation of choroidal plexus, and more recently, much more articles related to ventricular lavage to treat this special group of patients. Serial lumbar puncture and ventricular device, there is no evidence that really decrease the placement of a permanent shunt. When we compare the ventricular device with subgaleal shunts, we have evidence level 2 that reduce the daily CSF aspiration when compared with the device in favor of ventriculo-subgaleal shunt. But we have this aesthetical issue that we need to deal with and to talk about the family about the results. we have controversial findings related to ventricular subgaleal shunt. There is this comparison, ventricular subgaleal shunt with reservoir. There is no observation difference in the infants underwent conversion for permanent shunt at 6 months. But this work from Sandeep Chatterjee, the Kolkata group, shows that maybe we can have shunt-free in some of these patients. Doesn't matter what kind of etiology is related. And since this, we start to work together with the pediatrician and the family. It tried to establish ventricular subgaleal shunt in our pool of patients. Before, we treat only with ventricular lavage, with or without external ventricular lavage, external ventricular drain. Now we combine these all options, in this case, particular case, Bernardo, with intraventricular hemorrhage and meningitis. We treat with ventricular lavage twice, external ventricular drain, and also subgaleal shunt before to do a VP shunt. He's under investigation for immunodeficiency. It was a very difficult case to treat. And the surgery for ventricular subgaleal shunt is quick and simple as ventricular external ventricular drainage. We use with a valve or without valve. We don't have this certitude what is better. Sandeep recommend with valve in this subgaleal shunt. This is the patient. The less than half an hour surgery is quite okay, and the aspiration when the pouch can be every week or even every 2 or 3 weeks, depending on the drainage. This very important paper coming out from Egypt, randomizing ventricular subgaleal shunt and external ventricular drainage. The duration of ventricular subgaleal shunt can be the double time than external ventricular drainage, and the advantage is mobility. Even when we have more complication related to ventricular subgaleal shunt, has blockage, subdural collection, slippage, or bone remodeling, we see at the end of the day less days in internal unit hospitalization and less day hospitalization. The patient can be treated at home. And little by little, we are moving from external ventricular drainage for ventricular subgaleal drain. Is not anymore external drain our first treatment for intraventricular hemorrhage in neonatals, but we can combine. In some cases, we still using, like this case, for example, is postnatal myelomeningocele repair with CSF collection on the scar. And we decide to put an EVD just to help this scar on myelomeningocele to solve the problem. When we put AVD, we try to be a short externalization of the catheter and quick connection with the external catheter, try to occlude the communication in a sterile way, the internal, the intracranial with the external device. More and more, we find in the literature papers showing about neuroendoscopic lavage, showing decrease of overall shunt revision and shunt dependence in this group of patients. This paper from Padayashi about neuroendoscopy shows us that endoscopic lavage can be also a temporary treatment for hydrocephalus when we have bleeding or infection associated with hydrocephalus. What the rationale to do the ventricular lavage is a more aggressive evacuation of the blood from the ventricles in early phase of the post-hemorrhagic hydrocephalus, and maybe decrease the complication associated with this chronic hydrocephalus. And this trophy prospective registry is ongoing. We see the partial results at the moment. 40% of these patients are already being submitted to a ventricular lavage, neuroendoscopic surgical procedure. In this particular patient, it was 4 months old with ventriculitis, also after myelomeningocele repair, with meningitis and ventriculitis. With the rigid endoscope, doing a lavage and aspiration, we cut the Fogarty, and with a syringe or with the aspirator, we just do the cleaning this tissue to try to shorten the time for antibiotics and the hospital stay. And it's the real result, as we see in several papers, not only for the bleeding, but also for infection. When we move the syringe to the aspirator, we see the quickly result on the aspiration. We need to pay attention to try to avoid the ependema when we are aspirating. The recommendation is to have 2 surgeons working, not only with the nurse's scrub for doing this kind of procedure, because we need to hold the endoscope and the second surgeon to aspirate this one. This was made with our resident 3rd year. And even though after, it was necessary to do a VP shunt for this patient. The last project, or at the beginning for me, is the Benjamin Wharf protocol, start on the Santa Casa in 2022 with Gisele Coelho and Milton Toita, and is treating this pool of the patient with flexible endoscope. For us, I'm more comfortable at the moment with the rigid endoscope. We are just starting the new project with ETV+CPC to try to help or to have another tool to use for this patient. The indication is between 3 to 6 months and 2 kilograms below 2 years of age. No infection, and anatomy, favorable anatomy, doesn't matter the etiology, and the MRI and T2 or in sagittal window is the best image or Fiesta to decide if it is a good case for ETV+CPC or if not a good case. The position is different. In rigid endoscope, we do in a regular position, standard, vertical, and on this protocol is lateral position, and the incision is the cocker, the same, and with open the dura and close the dura with stitches to avoid CSF fistula. The flexible endoscope is by stores that we are using now. And one of our recent cases, it was 5 months old baby with hydrocephalus with all the clinical manifestation needing a surgery. And the anatomy looked like okay for the endoscopy. And the difference from the ATV with the rigid now to the flexible is we doesn't start with the Fogarty, we start with the barbed wire. We localize the same anatomy, the mammillary bodies, the infundibulum, and with the wire we just open the tubercinarium, the first. And after we go with the Fogarty 3.0, in this case is only Edwards in our country. Is not every 3 French that's working. It's only this one that we can perceive and try to see how better we can expose the basilar artery to be sure that we open or the cistern and look inside how we can localize and be sure that we open all the cistern before to go the coagulation of the choroidal plexus. The postoperative period, usually we don't have small ventricles like we have in VP shunt still, but clinically we need to see the head circumference and ultrasound to be sure that the procedure is okay. This partial result is from our resident that is working on it. The etiology was prematurity in 1/3 of these patients, and between 53 patients remain shunt-free, almost 8% at the moment. And 20% of this failure was related to CSF fistula or infections. And the results in 8 patients, the anatomy wasn't perfect. We performed the surgery, but at the same time wasn't possible to do ETV+CPC, and we implant the shunt at the same time. In summary, hydrocephalus temporary treatment, we have AVD, subcutaneous reservoir, ventricular subgaleal shunt, and ventricular lavage. Definitive treatment, we have ETV+CPC, redo ATV in some cases, and VP shunt, as we know. And what the best time for the VP shunt? There is no consensus, but around 1.5 kilograms of the baby can be a safe option. In summary, intraventricular hemorrhage or ventriculitis, ventricular lavage, our first option. Below 3 months, ventricular subgaleal shunt. Between 2.5 and 3 months to 2 years, ATV+CPC if the anatomy is feasible. And above 2 years, ATV or shunt. Take-home message, guidelines are important, but we need to analyze our reality and see what is possible to do. The database can guide the comparison for the future. Educate people, our environment is always continuous, necessary, and ready to do endoscopic surgery at all time. And we hope we can meet all of you in Cairo, Egypt next October for this 52 annual meeting of the ESPN. And thanks a lot for this kind invitation. It's a privilege for me to be with all of you. Thank you.
Thank you, Nels. That was just an exceptional overview. Thank you so much for taking your time and for sharing your expertise. I think it was really, really even more than we asked you to do. So, John, quickly, I think if you don't mind, just I think Teddy may still be in the Teddy's in the panelist, and Mohammed Al Baltaghi's joined. So before I say anything else, I'm going to invite Mohammed just to say a few words. Welcome, thank you, and a little bit about the ISPN Cairo. Mohammed.
Hi, everyone. It's nice to meet you. And I'm sorry I'm at the OR. I had to scrub in 10 minutes, but I would like to welcome everyone to the ISPN in Cairo in 7 to 10 October 2026. We need your support. Actually, this is in Africa back after 17 years from being in South Africa, which we will need actually the support of all African pediatric neurosurgeons. And I hope to see you all there. And thanks, Llewellyn, for this nice webinar. And again, sorry for not being able to continue because I had to scrub.
No worries, Mo. Thanks so much. I think one of our main goals, apart from promoting the AFPNS, is to push for attendance in Cairo. Mo, so I'm just going to make a point quickly that John has sent me a message about. John, you can verify this. I see we had nearly 120 participants at some point, John, and you say this is the largest attendance this year so far, right?
Yeah, it's the biggest crowd. Way to go, guys.
Now, thanks, John. Thanks to you. Thanks for all the effort. And really, I think more than half of our attendees are African. In fact, and we'll do a count afterwards. So really, tremendous success. Okay, so our next speaker, and Mo, I'll go on and introduce our next speaker. So Teddy Totima is a Ghanaian neurosurgeon from Accra who I had the privilege of working with closely over many years now, both in Ghana, where Teddy hosted the ISPN course, and he really had a big kind of almost one of the pioneering efforts for AFPNS. Ted, you can vet that for me. And Teddy came to visit in South Africa as well, so I got to meet him and his family. So Teddy's really made huge contributions to pediatric and adult neurosurgery as well, Ted, in Ghana and beyond. So really a pleasure to welcome Teddy, who's a fundamental pillar of our African Pediatric Neurosurgery Section. Ted, I'm going to hand over to you, yeah?
Thank you very much. Ellen, I think you have to shunt me after this because you've made me get a big head. But you know, I think it's a real good opportunity to learn about this hydrocephalus problem. I thought I would look at it from a perspective of two cases, actually three cases that I handled, and sort of discuss our approach, and also the importance of, you know, having a multimodal way of looking at this problem, especially in our environment. So we all know what hydrocephalus is, the fact that it's either an obstruction problem or a production problem. And it's also could be a decreased absorption problem. And the fact that, you know, in Africa, post-infectious hydrocephalus is so common that I think one of the most recent comprehensive studies divided into either post-infectious hydrocephalus or non-post-infectious hydrocephalus. And I think it's a useful way of looking at it, and assuming that in our environment, most of the hydrocephalus that we would see would be, you know, post-infectious. But the thing is, you know, accepting this as the reality means that we should have management options that fit the reality of the types of hydrocephalus that we see on the continent. We can see from this graph that on a continent which has significantly high levels of hydrocephalus, shunt placement is the most common treatment. And this is across all the etiologies. And like I said, we just talked about the fact that we have to look at it on the continent as either post-infectious or non-post-infectious, with post-infectious as a majority, right? But if shunt placement is the most common treatment, then it means that we're basically looking at this this problem through the barrel of a very, you know, simple gun. And that may be a difficulty when it comes to looking at these high numbers. This map that is shown on the screen has the sub-Saharan Africa in green and then North Africa in gray. But the thing is, you know, you have a pooled prevalence in Africa of 150 per 100,000. But actually, in many parts of sub-Saharan Africa, it can get up to as high as 750 per 100,000. And if there's such a big burden of, you know, post-infectious hydrocephalus, then we must look at addressing this problem in multiple different ways, because post-infectious hydrocephalus, it's a different beast when it comes to management. And, you know, the challenge of the complex hydrocephalus problem is the fact that it goes beyond just a simple plumbing problem, right? There's activity in the intraventricular space and then also extraventricular, right? So whereas in the IVH, intraventricular hemorrhage from prematurity, you have inflammation and associated scarring impacting mainly the intraventricular environment, and then impacting on absorption, and then also causing, parenchymal congestion because of the associated lymphatic disruption. The post-infectious type also adds to all this, significant formation of intraventricular septations, and so that there's both intraventricular effect and extraventricular effect, where the extraventricular effect is more looking at significant destruction of brain tissue, right? So both these can end up in, hydrocephalus being acute or delayed. Acute hydrocephalus would be more the intraventricular impact, whereas the delayed hydrocephalus would be more related to, the extraventricular impact, the lymphatic effect, and then bulk flow problems that cause congestion, and therefore, in addition to the, brain parenchymal distraction, would lead to poor cognitive prognosis for these babies. And so it's first important to have an eye on the problem as a common problem, and then secondly, have the strategies that we need to solve this problem. It so happens that Africa would have 1% of the world's neurosurgeons, an even smaller percentage of the world's pediatric neurosurgeons, and so we are sort of put in a place where dealing with complex hydrocephalus is a difficulty. But I think that accepting the problem and focusing on it is a good first step, and I think that is one of the lessons that I want to sort of stress on as I look at these three cases. So the first case is a 27-year-old premature baby, was diagnosed intrauterine with hydrocephalus, and then in our environment, there's difficulty with initial premature care, and so perinatal sepsis is a bit more common than it should be, right? So developed perinatal sepsis, got treated, survived, and then the neonatologist noticed the head circumference was increasing. So we saw the head circumference was significantly above what it should be. We did a ventricular shunt, post neuroendoscopic lavage, and then we were able to get 2 months of stable head circumference. After 2 months, we did not tap the galeal pouch, but we noticed it was really tight, and the head circumference was increasing. At this point, we decided to do an ETV and remove the ventricular subgaleal shunt, and basically use the ETV to sort of buy us some time before we look at putting in a shunt. And so this is what we did. And after 4 months, the ETV failed. But at this time, baby was stable, and we were able to put in a VP shunt. Now, a VP shunt held for the next 6 months, but then the head circumference started growing, and we took back to theater and realized that it was really a valve problem. We changed to a low pressure valve, and there was an initial overdraining, but the baby stabilized, and even though the milestones are significantly delayed, the mother is grateful that they do not have to keep coming back to the hospital. And we have reviewed the baby over the last 3 years, and he is stable and has not needed any treatment on the hydrocephalic front. The second patient that I want to discuss had a more rocky, post first intervention course, and she was also diagnosed intrauterine, and then born 27 weeks premature, neonatal sepsis, and treated until the culture of the blood cleared, and was born normal cephalic. And then at 4 months, the head circumference started slowly increasing. So she was brought to us, initially looking at how significant the post-infectious changes were in the brain. My tendency was just to do a simple guided ventricular catheter across the cysts. So, and the ultrasound guidance just put a long ventricular catheter across as many cysts as I could. Now, head circumference was stable for a month and then started increasing. The key reason why I wanted to be limited in the beginning was just in terms of prognosis. And I guess I was sort of impacted by the image that I was seeing. But when the head circumference started growing again, this time we just decided to go all out, did an endoscopic fenestration of as many septa as I could see, put in, realized that the VP shunt was actually having a proximal malfunction, replaced it transseptum posting, and then we closed. Now, this was a surgical intervention, and actually this baby did well. She did well, and then we had her coming back 6 months later with head circumference beginning to increase, and this time we noticed that she had developed a subdural hematoma, but the fontanelles were tight, firm. And so it was sort of a mixed picture between the malfunctioning shunt and then a previous subdural hematoma. And so again, we went in, and this time it was still a proximal malfunction. Catheter was taken out, and we took the opportunity at the time to do a re-fenestration of as many, septations as we could. This would only hold for a few weeks, and then she developed a fever. We realized, taking the CSF, that she had gotten infected, and we put in an EVD, at which point there was actually purulent ventriculitis. We treated with antibiotics that she was sensitive to until the CSF was clear, right? And then we did another septostomy and tried to clear as much of the path as we could, and put in another shunt. Now, this is what has held for the last, I think she's doing, the last 6 months now, and she has been stable. And the parents know that this is a complex problem. And we know that we're going to have holidays, and then we're going to have, sudden flights to the hospital. So it looks like for now, we'll just enjoy the holidays. She is doing well. She's doing physio, and she's obviously delayed, but she's a very happy camper when she comes for review. The last one is a baby that was shunted at 1 month for post-infectious hydrocephalus. And actually, the shunt has been working well. But the mother brought the baby because she was expecting better head and neck control, better head control, and she wasn't getting it. And we saw head circumference was actually just 1 centimeter above what it was supposed to be, and the fontanelle was flat and soft. But on the imaging, there was this, post-infectious cyst basically filling the entire third ventricle and pushing the brainstem forward. So the plan was to go in and fenestrate this cyst and go into the cyst and try and fenestrate any other septations that we could see. Now, we must notice that a lot of all these interventions are being done without neuronavigation. And so once we get in, try to, go along a calculated track, and then try to do as much of the fenestrations as we could, and try and stay safe at the same time. But, the CTs below are actually post, the first day post the endoscopic intervention. And I think I can already begin to see that the cyst is smaller. And this might be a bit subjective, but on the second day after surgery, the mother said she thought that the baby was a bit more active and was, trying a bit more to lift up the head. This baby is still 1 week after surgery, and I'm going to see him tomorrow. I'll see how he's doing. But I think I'm encouraged by the fact that this post-infectious cyst that was, causing significant pressure on the brainstem is a little decompressed. Now, on the movie, you can see that cyst just peeping out of the foramen of Monroe. There was a little bleeding as we went in, but it all settled with irrigation. And so the plan was just to basically go through that membrane at the foramen of Monroe, which introduced us into the main cyst, and then do the second fenestrations through that hole. So ultimately, I think in our environment, neuroendoscopy is indispensable for complex hydrocephalus. It offers, a diversification of our armamentarium, if I should say that. It gives us added advantage on the kinds of, strategies that we can use to treat this very common disease. And I think that early diagnosis is important, especially for improved cognitive outcome. And that we must remember that for post-infectious hydrocephalus, the intraventricular and extraventricular insult limit the impact of, a unimodal care, limit the impact of just one track neurosurgical treatment. And we should look at increasing the concentration on neuroendoscopic expertise and transfer on the continent. And I'm looking forward to what the African Pediatric Neurosurgery group will be able to do in this regard, because we need diversification of skills when it comes to treating hydrocephalus on the continent. Thank you very much.
Okay, thanks, Ted. Thanks for a really comprehensive talk and some lovely cases. I'm going to hand over to James Balogan to make some some comments just quickly. So James is a Nigerian neurosurgeon, highly respected, very active, and has been a prominent pillar, in neurosurgery in general, but is one of the pillars of our African Pediatric Neurosurgery Section as well. Thanks, James.
All right, thanks, Lowly. Particularly sorry, I've got some cold, so I've got some kind of nasal speech. But really just want to thank Teddy for this great work, and obviously the presentations that you made. And we really got some little questions just for you to clarify. I'm sure that those are things probably that you get asked in cases like this. We know that for us on this side of the world, we get this kind of complex cases, and you're trying to make an allusion for intervention using neuroendoscopy. So in your practice generally, rigid versus flexible, when it comes to these complex cases, or do you have to interchange, kind of do flexible and then do rigid case by case basis, or you're more familiar with a particular one? And what would you really tell the younger colleagues in terms of developing competency in neuroendoscopy? What's the deal to go through? I know Nelsie talked about the fact that she's changing practice now, particularly with from rigid to flexible. I know that those who learn with rigid are really rigid. So I kind of just want to hear what you have to say about that. I think the other part that I also would like you to kind of throw some light, it's the fact that you showed a slide, and Nelsie also showed a slide earlier on, which are really a little bit different from each other. And you mentioned the fact that post-infectious hydrocephalus is more common in our own environment, and you show that, which is a study which was just a slight increase compared to the non-infectious. And in the second patient that you showed really was a preemie, and child had intraventricular hemorrhage and now had an infection. So the question is, oftentimes what we call post-infectious hydrocephalus, is it really post-infectious hydrocephalus, or is hydrocephalus that's now infected? So I think those are the questions, because again, it generates all of these complex cases where you have people tapping or doing ventricular taps or doing all kinds of stuff, and patients presents to you with these multi-complex cysts in the brain. And like you said, oftentimes you're also challenged not just with the intraventricular issues, but with the extraventricular status of the brain itself. So I mean, these are thoughts that we always come through for us over the years. And I just like, since you presented these complex cases and what the challenges are for you, maybe you can also throw in your perspective. Thank you.
Yeah, I think first of all, I'm more. I think I would be one of your rigid people because I'm more comfortable with the rigid scope. It is what I was basically trained with. I didn't really have too much of an access to the flexible scope, and so I do much more with the rigid scope. I find the optics much better with the rigid scope. I have found that the flexible can be very useful when it comes to, finding things, within the ventricle, and being able to get, trajectories for like finding the aqueduct and things like that. But I sort of think that if there's a lot of real planning before the intervention, it is possible to get really interesting trajectories with a rigid scope, just by the careful planning of the trajectory. And so far, I have not really seen a handicap that, has resulted from not having the flexible scope. But I definitely have seen some advantages when it comes to, looking for specific things, and then also, getting well oriented within the ventricle. But I would say to our younger colleagues, definitely, if you get the opportunity to learn the flexible, it's a good thing to add to the rigid scope. But I think that they should be used together. And because if a flexible scope is just used alone, I think that there's some sacrifice of visualization. And because I'm not sure that especially on our continent, we can get flexible scopes which have as good optics as the rigid scope. As to the post-infectious, post-intraventricular hemorrhage thing, I think that you're absolutely right. But I think ultimately in our environment, considering the challenges in the perinatal period, we have to accept the fact that the tendency towards post-infectious hydrocephalus is much greater. And considering the fact that, yes, you can have brain destruction with just post-intraventricular hemorrhage hydrocephalus. However, when you look at what we get from these babies when there's significant sepsis, and you see what has happened to the brain, it can be it's just outrageous what can happen to these brains. I think that the only usefulness that comes from looking at hydrocephalus in our environment as a post-infectious phenomenon primarily would be that maybe it makes us more aggressive at finding out the infectious status of the baby, finding out, not just settling because maybe a blood culture is negative, but looking for other things and really concentrating on the clinical features and the laboratory features from the beginning. Because once these infections get set in, then the destruction can be significant. So I would completely agree with the fact that, yes, and sometimes it's difficult to tell between what is happening post-intraventricular hemorrhage and what is happening post-infectious. But I think that in our environment, we would be more helpful to the babies if we have a high index of suspicion for hydrocephalus being post-infectious.
All right, thank you. I'll just hand over to Leoline, because I think there are two more speakers, and then we can continue. Thanks.
Thanks, James. No, those were incredibly useful points. Nels, you want to make any comments on that? Just the use of flexible versus rigid endoscopy. You made a comment about choroid plexus cauterization. So what's your preference? Nels, I see you still on the call.
Okay, thank you. Very interesting comment, James Balogun. For those that are using rigid endoscope, are more rigid, maybe more rigid person, steady, tell us, maybe it's right, because we feel much more comfortable. At the beginning, I thought it was only because the image is a little bit more clear in the rigid than the flexible. But I think in the last years, the flexible became more clear, more effective. If you have a good screen, you can do it. But if you are planning to do ETV+CPC, I think you need to be trained on the flexible endoscope. Only for ETV, I feel more comfortable with the rigid. For the child that are more than 2 years old, that doesn't indicate CPC, we prefer to use the rigid endoscope. But ETV+CPC, I think the flexible really have more feasibility than the rigid one. And just a comment for the complex hydrocephalus, Teddy. Did you use time to time on real-time ultrasound? Because complex hydrocephalus, multiloculated, time to time we go in, but we doesn't know where we are. Small children, several loculations. I have only one child at the beginning, maybe 20 years ago, that my septation give the child hemiparesias on postoperative. Probably we doesn't perceive that we are in the tracts, the pyramidal tracts, and we do some damage during this septostomy. Just to hear from you, because now we have a small ultrasound with the possibility to bring with us with the mobile, something like that. I doesn't jump in yet, but I know I need to go in some time. I just would like to know if you are already on this, that you do the endoscopy, the septostomy were guided by ultrasound. We know there is several colleagues doing it, but I'm not in at the moment. Thank you.
At the moment, yes, at the moment, I would generally do the initial septostomy with the ultrasound, and I haven't used the two. Usually for the septostomy and with endoscopy, I'll just have a pre-calculated trajectory that I use, and try to stay as safe as I can. But I completely agree with you on getting lost. And sometimes that is what stops me from going further with multiple, fenestrations. There's one time when, like in this particular patient, the first time when I was just passing the catheter across, I used the ultrasound just to get an orientation so that I could just pass the catheter through. But apart from that, usually I would have a predetermined trajectory, and then use the endoscope to do as many fenestrations as I can safely do. And as soon as I don't feel safe, I stop. The thing is just knowing when to stop, and I don't know when to stop. Yeah.
Okay, thanks, Ted. Thanks, Nelsie. Just to comment quickly on that sort of ultrasound-guided neuroendoscopy. We've pushed that quite hard through several teaching courses, and we've published on that as well. I think it's really useful as a guide. Like Nelsie says, once you're in there, the anatomy is so complex that it's easier to get lost than not. So we found it to be a really beneficial, easily implementable, repeatable tool. So I completely agree with you, Nels. We've got some questions quickly. I'm going to try and just see if we can get, John, if you don't mind, we get them to ask their own questions. I see you did get Meram Jealous Banner, I hope I'm saying that correctly, who's asked more than one question. Meram, do you want to ask your question? I think John's giving you.
Yes. So first of all, thank you for your clear presentation and wonderful presentation, Professor Teddy. As a medical student, may I ask you, given that Africa bears the highest burden of post-infectious hydrocephalus, yet relies predominantly on VP shunting, do you think the next major advance should be technical innovation, or rather the development of continent-specific treatment algorithms that stratify patients by inflammatory burden, cyst, complexity, and parenchymal injury? And if so, what single variable would you prioritize to build such an algorithm? Thank you.
Well, thank you very much. I think that your first point is the most important. The fact that we should, first of all, get the technology on the continent, and we should, Llewellyn has been doing a lot of work with teaching about the ultrasound, for example, adopting this technology so that it becomes available wherever we can do it. And we should do the same with neuroendoscopy, making the technology available on the continent, having the scopes that enable, people to do this. The screens that we have, the quality of the cameras that we have. So in terms of technological innovation, I would completely agree with you. I think that a lot of the algorithms and the scoring systems are already available, and we do not need to invent the wheel. A lot of them can be adopted quite easily, and we should use them. But I think that, first of all, the technology coming on the continent, and secondly, the teaching so that the expertise goes with the technology are even more useful. I saw a question about the ETV score and whether I depend on it. I think it's a very, very useful score. It provides a way of making decisions. But I think that in our environment, when an ETV fails, we've got a big problem, because it means trying to get back into the OR, trying to, start something. So I use the score, but I try to make sure that it's only those who are very high on the score that I do the ETV for. I do not, use, medium scores. I want to make sure that whenever I do an ETV, it is going to be as successful as possible. And I think that in our environment, it is very important, whatever algorithms we use, to remember the limitations of our environment and how difficult it can be sometimes to get a baby back into the OR to sort out a problem. Yes, so I would say my chief focus would be technological innovation, get the expertise to as many people as possible, and then use the algorithms that already exist.
Thank you, Professor.
You're welcome.
Ma'am, quickly tell me, where are you from?
From Tunisia, north of Africa.
I see.
Okay.
Oh.
Thank you.
Okay, Ted, thanks so much. So just a reminder quickly that we've got a tremendous attendance. This is a Sunday afternoon, which I think John makes this even more impactful. So thanks for suggesting that. Our next speaker is from Ethiopia, Addis Ababa. Ebenezer Tirsett is somebody I've got to know very well over the last few years. Again, has been a fundamental pillar in building and spreading the word and really encouraging membership for the African Pediatric Neurosurgery Section. So Ebenezer, it's a great pleasure for me to introduce you to give our next talk. Thanks, Ebenezer.
Thank you, Llewellyn, for the kind invitation, and the African Pediatric Neurosurgery Sections, and I Spain for the opportunity to learn about hydrocephalus and CSF disorder. I will be presenting about management of neural tube defect related hydrocephalus. So I will try to briefly go through the pathophysiology of neural tube defect related hydrocephalus and the epidemiology. Then I'll try to explore the different treatment options and compare the different treatment options and show some of the outcomes in different publications and complication reported. And finally, I will try to highlight challenges and some possible future directions. So as you all know, neural tube defect is a result of failure of neural tube closure around the 28 days of gestation, and it could be due to failure of the primary or secondary neurulation, resulting in the different spectrums of the neural tubes defects. And when we see the pathophysiology of neural tube defect related hydrocephalus, it's usually complex, and there are different hypotheses explaining how the hydrocephalus develop in this group of children. And the two commonly used are those who relating the development of hydrocephalus with the presence of venous insufficiency, and the other is with having active CSF leak from the open defect during the fetal life. So the first hypothesis states that the hydrocephalus progress because of the venous insufficiency, and the presence of the craniocervical pressure gradient difference results in hindbrain herniations, which will subsequently form the Chiari malformation, and the Chiari will be responsible for the obstruction of the CSF flow, resulting in elevated intracranial pressure. And this group of children are reported to have reduced brain compliance, increasing their vulnerability for permanent brain damage and ischemias. And the other hypothesis states that the hydrocephalus developed because of the presence of constant CSF leak through the open defect during the fetal period, which subsequently result the Chiari malformations. And because of the leak of the CSF, the normal distension of the ventricular system within this fetal period is very important for the development of the CSF pathways. And when there is a consistent CSF leak through the open defect, this results in impairment in the development of the brain as well as the normal CSF pathways, resulting in the ultimate caudal descent of the hindbrain and the hydrocephalus developments. So there is some of the results of the MEMS trial, which compared the outcomes of prenatal versus postnatal closure for neural tube defect, also emphasizes the fact that this open defect and the CSF leak could be one of the causes. And on this trial, when they compare the two groups, they have clearly showed that the need for permanent ventriculoperitoneal shunt placement is less on the prenatal closure group, and the severity of the Chiari malformation was also less on the prenatal groups, stating that if the neural tube defect is treated early during the fetal period, it could arrest the progress of the diseases. Additional factors for the development of hydrocephalus in this group of children include the presence of aqueductal obstructions, forced ventricular outlet obstruction, obliteration of the subarachnoid space due to crowded posterior fossa, and due to the presence of steep tentorium, obstruction of the CSF pathway at the tentorium hiatus, and some also reported that the presence of abnormally developed arachnoid granulation contribute for the development of hydrocephalus in this group of children. So we see both communicating and non-communicating type of hydrocephalus in this group of children, and the non-communicating hydrocephalus is more common one, and it's where the blockage of the CSF is prevented due to the anomalies resulting in raised intracranial pressure. So when we see the epidemiology, so different studies have reported that 80 to 90% of infants with especially severe form of spina bifida develop hydrocephalus, and the CSF diversion rate for the treatment of hydrocephalus in this group of patients vary from 40 to 90% according to different literature reports. And specifically in the postnatal closure group, the need for the permanent CSF diversion reported range from 50 to 90% generally. And as presented by our earlier speakers,
Okay, just hold on.
hydrocephalus is one of the in Africa, and according to a systemic review report reporting on hydrocephalus across Africa, they have reported that it is the fourth commonest cause of hydrocephalus in Africa. So another global systemic review on pediatric hydrocephalus have showed that globally neural tube defect related hydrocephalus is one of the commonest cause of congenital hydrocephalus, and they have reviewed the course through 11 years period, and they have showed that the incidence of neural tube defect related hydrocephalus is more or stable in different regions as when they compare regions with mandatory and non-mandatory folate fortifications. Another systemic review and meta-analysis on global burden of hydrocephalus incidence plus prevalence have compared the incidence in LMICs and high-income countries, and it showed that the incidence of neural tube defect related hydrocephalus is higher in the LMICs as compared to high-income countries, but the incidence of new cases of neural tube defect associated hydrocephalus is significantly higher in LMICs as compared to high-income countries. This could be due to the higher crude birth rate, among the other reasons for this. So this is another important epidemiologic report. So when we come to the diagnosis and clinical detections, prenatal early detection is very important for timely interventions and which significantly improves outcome. And prenatal diagnosis is usually made through ultrasound. So the MRI, fetal MRI, is a golden standard, and increased serum or amniotic fluid alpha fetoprotein also indicates an increased risk of having fetus with neural tube defect. And postnatally, usually a clinical examination is very important, and MRI scannings and ultrasounds are important to see the severity of the defect and the presence of other associated congenital malformations. So when we it's always important to decide on the timings for treatment, and when we think of planning the treatment, so one important factor on this complex pathophysiology is the time where we detect the hydrocephalus. And in some group of patients, the hydrocephalus develop prenatally, and prenatally fetuses may have significant ventriculomegaly, and some group of children develop the hydrocephalus progressively during the early neonatal period, and some group of children develop the hydrocephalus after the myelomeningocele closure. And we always need to correlate the clinical findings with the imaging findings on ventriculomegaly to decide on the treatment. So one treatment modality for this group of patients is conservative management. A neurologically stable infant with stable or slowly progressive increment in the ventricular size can be carefully followed conservatively, and reports showed that this has significantly reduced the shunt dependencies, and reports have showed from UK showed the reduce in shunt dependency as low as 51%, and patients who are managed conservatively usually will have mild to moderate chronic ventriculomegaly, and the effect of this chronic condition need further studies, especially the effect on neurocognitive outcomes. So when we see the indications for interventions among the different indications, some of the clear indications to intervene the hydrocephalus is rapidly increasing head circumference, as shown by the head circumference chart for age and sex specific. And if the child has increment in head circumference crossing 2 lines in consecutive follow-ups, that's one clear indication. And the other is if the children have severe hydrocephalus, as seen on the chart from the initial presentations, and bulged or tense fontanelles and signs of raised intracranial pressures like sunset eyes, and brainstem compression signs like hypnea, bradycardia, and signs of Chiari malformations, and feeding intolerance and progressive ventriculomegalies. Symptomatic ventriculomegalies are some of the clear indications for the surgical intervention. So when we see the modalities of surgical treatment, it includes ventriculoperitoneal shunt, which had been used most frequently around the world according to different reporters, and endoscopic third ventriculostomy with or without CPC is a newer treatment modality, and this treatment modality has been specifically recommended in sub-Saharan Africa, in Uganda, by Professor Warf, specifically for this group of children. And the other treatment modality is fetal surgery for closure of the spina bifida, which has shown a promising result, reducing the need for hydrocephalus treatment and reducing the development of severe Chiari malformations. So Professor Warf from Uganda reported the technique CPC plus ETV plus CPC has superior outcomes in children with less than 1 year with MMC associated hydrocephalus as compared to the post-infectious group, and recommended the use of ETV plus CPC for this group of children. So the other important aspect of management of neural tube defect associated hydrocephalus is timing of the surgical treatment. And if hydrocephalus is diagnosed prenatally, and immediate intervention after birth might not always be necessary. The decision to place a shunt or perform ETV depend on the severity of the hydrocephalus and the child's clinical condition. And typically, VP shunt is placed within few weeks of life, especially if the hydrocephalus is progressive, leading to symptoms of raised intracranial pressure. And in case we consider ETV, we might need to delay the procedure a bit until the infant is slightly older, depending on the anatomic considerations and the neurosurgeon's experience. And the timing and decision to proceed with surgery should always be balanced with the risk of having surgery versus the risk of untreated hydrocephalus. And for children with overt hydrocephalus at birth, NTD closure and hydrocephalus treatment in the same operation is recommended within 48 hours after delivery, and single stage surgery for treating the closure of neural tube defect plus hydrocephalus management is reported to be safer option. But in practice, in most setup, especially in our setups, we usually treat the neural tube defect first and subsequently manage the hydrocephalus, either immediately in severe cases or after careful observation in less urgent cases. So when we compare the two treatment options, VP shunt versus ETV plus or minus with or without CPCs, so ventriculoperitoneal shunt is frequently used in most setup, and it has higher early success, but the long-term complications and the shunt dependency is higher. And ETV with or without CPC in selected group of patients reduce the shunt dependency. Report have showed variable success, and always it's important to critically evaluate a specific patient to decide on the modality of management. And both treatment options have different complications, and the complication rate varies across the world depending on the setup and the patient conditions. And so shunt-related complication includes infection, shunt failure, over drainage, migration, bleeding, and multiple surgeries. And the infection rate reports show different infection rate in different parts of the world, and repeated surgery is reported to be associated with a lower cognitive outcome in long-term follow-ups. ETV also have complications like hemorrhage, infections, CSF leak, failure, in rare cases, neurologic injury, vascular injuries, and even mortality in rare cases. So when we see different reports, this is a global systemic review comparing the use of endoscope ETV versus ETV plus CPC for treatment of specifically myelomeningocele-related hydrocephalus. And this systemic review in total evaluate the outcome of 325 children, and has showed ETV plus CPC is associated with higher success rate as compared to ETV alone. And ETV with or without CPC is the study recommend ETV with or without CPC is technically a visible and safer option for this group of patients. This is another study from Nigeria which compared the outcome of ventriculoperitoneal shunt versus ETV plus CPC for this group of children, and the study has showed that ETV plus CPC has similar success rate with ventriculoperitoneal shunt during 6 months follow-up with lower morbidity, and advocate the use of ETV plus CPC for this group of patients. So when we see the experience and outcomes across different countries globally, it significantly varies, and in high-income countries, usually prenatal screening is available, early detection is available, advanced treatment modality like fetal surgery is available, resulting in better outcomes. And in middle-income countries, there is a disparity in access to treatment, but some group of patients get a high-end treatment, but some of the patients in this region may also suffer from delayed presentation and lack of access to treatments. And this is the report from, when we see the report from the MEMS tribe, they try to compare the prenatal surgery versus postnatal closure for the treatment of neural tube defect in centers in the US, and during the first and second MEMS follow-up periods, they have found that the need for shunt and the hindbrain herniation is better in the prenatal treated groups, and in during school age they have found that the independent mobility and the functioning is better in the prenatal closure group, and this is a very important study, and MEMS3 is coming. And this is another systemic review showing the treatment outcomes of neural tube defect related hydrocephalus in the US, and they have evaluated around 8,233 children over 15-year period, and when they see the treatment modalities, most children, almost 70%, got ventriculoperitoneal shunt and 24% receive endoscopic ventriculostomy, and the modality of treatment was more or less stable throughout the period, the 15-year period. But during over time, the delay in the management of hydrocephalus treatment is seen according to the different studies included on these systemic reviews. When we see the experience from low-income countries, specifically Sub-Saharan Africa, there is a higher incidence and enormous need, and there is a significant unmet need, resulting in poor outcomes, and there is a lot to be done specifically to improve the treatment outcome of this group of children. And a report in a single center in Uganda by WARF showed ETV plus CPC has higher success rate for treatment of children with a neural tube defect with myelomeningocele. And just to show you some of our experience, so in a hospital-based studies in Addis, we have found that NTD-related hydrocephalus is the most common etiology among the patients we treat, and we treat most of the patients with ventriculoperitoneal shunt. And we had higher ETV failure during that time, during the study period, and higher shunt infection also. And in another cohort where we compare the treatment outcome of neural tube defect over 6 years period in a single centers. So the first study had 88 study participants, and the second had 228 study participants. And we have found that presence of preoperative hydrocephalus is associated with mortality in children with neural tube defect in our setup, and there is an ongoing effort to improve the treatment of hydrocephalus in this group of patients to improve and the treatment outcomes. So when we see the some of the challenge in the topic, it's one is when to intervene, whether to intervene early or delay, and the other is how to select proper patients, and the other challenge is how we select the treatment options, and having follow-up and surveillance is also another challenge. So when we see the prognosis depends on the setup, so it varies across countries depending on the setup, and whereas in LMICs the prognosis is usually poor due to late presentations, limited access to treatment, and inadequate post-operative follow-up. So as a conclusion, NTD-related hydrocephalus is a complex and dynamic problem, and it presents a significant challenge globally, and clinical evaluation is always important along with imaging evaluation of this group of children, and VP shunt is a commonly used treatment options, while ETV with or without CPC is anywhere and viable alternative in our setup, and prenatal repair is a newer treatment options available only in few centers globally, and there should be a paradigm shift towards access to this prenatal closure at it, as reports show that it significantly improve outcomes in this group of children. And globally, high-income countries have made significant improvement on the treatment and prognosis, but globally speaking, we need to work to improve the outcomes of this group of children, and we always need better access to healthcare and public awareness. And as a future directions, newer and accessible modalities for early diagnosis and timely intervention, including availability of biomarkers, should be one thing we should look into, and refining the surgical treatment options, including the endoscopic technique training, like accessing training for surgeons, especially working in resource-limited setup, is very vital, and long-term neurocognitive outcome studies are important, and prenatal repair should be also accessible in areas with higher burden of the problem. Thank you very much, and please scan and register in African Pediatric Neurosurgery Section. Thank you.
Thanks, Ebenezer. That was an incredibly comprehensive overview. Thank you so much for your effort and time. I see we're running a little bit close to time there, John, so I'm going to move on to our next speaker. So our final speaker who's closing off this sort of group of 4 talk from AFPNS and from NELSI as well is Dr. Basil Anneke. John, I'm going to say we never dropped really below 110 odd participants throughout the webinar, which is just, I think, incredible for a Sunday afternoon. And I think speaks really to all our speakers, but to our last speaker as well, Baz. I think they're probably waiting to hear your talk. So Dr. Anneke is the head of neurosurgery at the University of KwaZulu-Natal in Durban. And he's really built a remarkable unit with subspecialist interests and quite a focus on pediatric neurosurgery. And I think Basil's recently completed his PhD on specifically this topic, which makes him a leading authority on all things hydrocephalus and post-infectious. So Baz, looking forward to your talk. Thanks.
Thank you, Professor Padayachi. Am I audible?
Yes, Baz, you are.
Yes, you can. I'm audible. Okay. Thank you for this opportunity to present on management of post-infectious hydrocephalus and global trends. Let me see if I can move on to the next slide. All right, and then thank you to the Llewellyn as well, and the organizing committee, Mohammed, who's the next chair of the ISPN in Egypt, and all the speakers that have given wonderful talks ahead of me, and the panelists that are involved in this section, right? I've got no conflicts of interest to declare. As we all know, which is the main reason why this African Pediatric Society Pediatric Neurosurgery Society was developed, is that in Africa, we know that we have the youngest population. Most children of the world live and reside in Africa. Hence, pediatric neurosurgery is such a very essential service that we as African neurosurgeons need to render, and we need to come up with African-based solution for African-based pathologies. As we all know, children less than 15 years of age comprise 40% of the population when compared to the worldwide average of 25%. Most of you are familiar with this wonderful article that came out a few years ago that essentially shows that Latin America and Africa have the highest incidence of hydrocephalus, right? When you look at the new annual cases of hydrocephalus, Africa has the largest number and also the largest number of pediatric hydrocephalus. If you count down to it as well, post-infectious hydrocephalus, if you count down to it as well, Africa bears the highest burden of PIH when you look at the paper at 66.6%. And all the new cases of PIH are highest in Africa, followed by Southeast Asia region and Latin America, of course, right? If you look at this paper that came out a few years ago that looked at, let's just look at 38 studies from 18 African countries, right? PIH, post-infectious hydrocephalus, made up a majority of etiology of hydrocephalus in Africa, followed by non-PIH, spinal dysraphism, and unclear pathology. However, though, there is variability in terms of the etiology of pediatric hydrocephalus in Africa, with some studies such as this that you see on the slide, which collected the pediatric patients from Zimbabwe, Namibia, and the Democratic Republic of Congo, where aqueduct stenosis was the predominant etiology. And this old paper that came out of Kenya quite a while ago, where spina bifida made up 43.4% of etiology of hydrocephalus, followed by post-infectious hydrocephalus, right? If you look across Asia, generally across Asia, non-PA, if you look at the systematic review, non-PIH made up 29% of pediatric hydrocephalus, with PIH at 10.7%. However, when they looked at the pool proportion of PIH across LMIC countries in Southeast Asia, post-infectious hydrocephalus infections were still the number one etiology of hydrocephalus in those countries. As Lowland has said, I'm based in KwaZulu-Natal in South Africa, where I practice in a hospital called Inkosi Apelutuli, which is a population of 12 million, and we have one of the highest second highest pediatric population in the country, following Gauteng. If you look at the etiology of the pediatric hydrocephalus in the center where I work, a majority will be non-PIH, but you can see a big burden is still caused by post-infectious hydrocephalus as a category of hydrocephalus. As non-PH includes all the other hydrocephalus pathologies that are not related to infection. And that this has become really stable across a 20-year period as well in the center. When you come down to what is the etiology of this post-infectious hydrocephalus, TB is the highest etiology, is the number one cause. But over the years, the number of TB cases have declined, and polygenic meningitis cases have slightly increased. I think that could be probably attributable to increase in awareness of vaccination strategies such as the PISA ACG and all the vaccines that are given a children at birth. Globally, there's an interesting paper that came out of the Lancet recently that looked at the global estimates of sepsis incidence and mortality from 1990 to 2020. You can see there were almost 20 million cases of sepsis in children, and with 2.9 million deaths, which is a 4.3 mortality in children less than 5 years old, comparable to those who are 5 to 19 years, where there's been 4.5 million cases, and of which only 10% of 10% mortality. If you look at the the most common causative pathologies, they're variable. As you can see, LMIC in high income countries have different etiologies when it relates to hydrocephalus, particularly as well if you're going to look at neonatal meningitis or early other causes of sepsis, which can result in hydrocephalus. Going down back to bacterial and pathogenic meningitis, the incidence of neonatal meningitis varies, right? And it's been reported as 0.2 to 0.5 per 1,000 live births. In South Africa, the incidence is particularly high at 18.7, while in the US it ranges between 4.5 to 9.7, and in the UK from 6.1 per 1,000, right? Okay. So what happens is that the post-infectious hydrocephalus can be described as an accumulation of CSF within the ventricular system due to an acute or chronic infection. And this infection can either occur in the prenatal, neonatal, and postnatal period. Why it is so common in young children is because of the immature immune system. And this infection can either be directly because of meningitis, or children can have a high-grade bacteremia with invasion of the meninges because the pathogens will cross the blood-brain barrier. And this triggers a very intense pro-inflammatory reaction, right? Which causes a lot of scarring, fibrin adhesions in the ventricles, the arachnoid villi, the basal cisterns, and also obstruction of the ventricles by debris leading into hydrocephalus. If you look at South Africa, and if you come down in South Africa has 9 provinces. And if you look at the provinces, the highest incidence of bacterial meningitis is highest in the Gauteng, where the capital of South Africa is at 13.9 per 1,000 births. And where I am at KZN is 8.2 per 1,000 live births. And this is quite important, because again, post-infectious hydrocephalus is a common etiology in children. The same study conducted in South Africa from 2014 to 2019 showed that the most common culture confirmed neonatal bloodstream infection are caused by gram-negative bacteria, followed by gram-positive bacteria, of which the organisms were isolated remain Klebsiella pneumoniae, Acinetobacter, and Staphylococcus aureus. Again, I think there might be the same issue that is faced by many hospitals across South Africa, because hospitals are often categorized into central, tertiary, regional, district hospital, and clinics. And this study had shown that national and central tertiary hospitals show a high incidence of resistant gram-negative bacteria, 60%, followed by gram-positive bacteria. And this is attributed to variation in antibiotic prescribing practices among the different hospitals and access to advanced treatment cares. Neurosurgeons working in LMIC often encounter infants with hydrocephalus with no documented history of meningitis. I think there's a clue if you see a child, and often we don't know what is the cause of the hydrocephalus. I think the clues that can give you to an etiology of post-infectious hydrocephalus will be a prior history of fever, ventricular locations on cranial ultrasound or CT or MRI scan. And if you put in a scope into the ventricles, if you see a lot of ependymal scarring, that is often suggestive of post-infectious hydrocephalus, as often because the etiology might not be unknown. Just to come back as well to vaccination, I mean, in South Africa, at birth, all children are given BCG. I think that is aimed towards preventing complications of TB, such as TB meningitis. I mean, there is a vaccination as well, schedules that is given to children, and that has been effective as well in decreasing the incidence of Haemophilus influenza meningitis in children. As you know, that used to be complicated as well by subdural effusion, which is quite a rare phenomenon at the moment. Again, living in sub-Saharan Africa with a high incidence of HIV transmission as well. I mean, the PMCT program in South Africa, which is the prevention of mother-to-child transmission, I think has done phenomenal work in reducing the risk of vertical transmission of HIV from mother to child during delivery. So how do we manage post-infectious hydrocephalus? We need to get a sample. There's a critical first step. Often these children present with features of raised intracranial pressure and MRI or radiological features suggestive of hydrocephalus. CSF is quite critical where it's sent for microscopic culture sensitivity, because that will allow for tailored intravenous antibiotic often these children are treated for up to 14 days, and they can be treated either with IV drugs or with intraventricular antibiotics. And it's quite crucial as well to monitor inflammatory markers such as the white cell count, the CRP, or calcitonin, because that will give you a guide as to the response to your therapy. Your temporal surgical management, I think the previous speakers, Prof. Zanan and Teddy, have given wonderful talks about how EVDs are used, ventricular subgaleal shunt. I think those are the options that you can use in children with the post-infectious hydrocephalus, including neuroendoscopic ventricular lavage, particularly in children with ventriculitis. As you know, ventriculitis is shown in the scan in the MRI on my left here. You can see this patient has an abscess, and then it's broken as well into the ventricle. There's the ventricles, this ventriculomegaly, and you can see there's enhancements of the appendyma. This patient has ventriculitis. At a later stage, with multiple treatments, long-term antibiotics, this ventriculitis can often lead to complex hydrocephalus, as shown on the MRI on the left, where then you get compartmentalized ventricles, making it difficult to treat the hydrocephalus. The permanent CSF diversion procedures range from very shunt insections. We prefer as well, particularly in patients with post-infectious hydrocephalus. In our environment, we use a lot of antibiotic impregnated shunt because in order to reduce the incidence of complications. ETVs as well is a strategy that can be used, plus or minus CPC. In our environment, we don't perform a lot of CPCs, but there's been a lot of articles that have come out in the literature that have supported as well and showed very good outcomes with ETV plus CPC in patients with post-infectious hydrocephalus and endoscopic fenestrations of loculations if we're dealing with patients with a multiloculated hydrocephalus as a complication of infection. The agents that we use in our center will be navigations, where we track the scope as we put a navigation on the scope and track it through the operation, and we also make use of the ultrasound. And I think Teddy has shown as well wonderful videos on fenestrations of these complex hydrocephalus cases. I mean, in South Africa, particularly in the Eastern Cape, and I think in parts of Latin America as well, neurocysticercosis is one of the causes of hydrocephalus in pediatric cases, and then it can present in for the 4 stages of the life cycle of these parasites, which is vesicular, colloidal, granular, and calcified. And 15% to 30% of cases of children or cases with the neurocysticercosis will present with hydrocephalus. If I go to this case, this is the case of this. This is a video of the scan that I shown previously, where we had a 9-year-old child who presented with intraventricular neurocysticercosis. We're starting on treatment, albendazole, but this was very resistant to antihelmintic treatment, and the cysts were very large. And we treated this child multiple times, and we went in and removed some of the cysts endoscopically because we were blocking the ventricles and blocking the aqueduct as well. This child had gone to theater multiple times and required multiple shunt revision. As you can see in the appendyma, there's a lot of scarring as well because of the intense inflammatory reaction that was caused by this neurocysticercosis cyst. Post-operative, as you can see, these are all the cysts that were removed during the procedure. This child had long-term treatment with poor response, and eventually with multiple shunt abnormalities and blockages, this child developed complex hydrocephalus with a lot of scarring in the ventricle and required endoscopic fenestration. 2.5% of all our pediatric cases with post-infectious hydrocephalus that we treat have HIV co-infection. This has been on the decline as well, I've said before, because of the prevention of mother-to-child therapy, and as well because in South Africa from 2016, all patients as well were given ARVs regardless of the CD4 count. And often there's also an association between tuberculous meningitis and HIV. And tuberculous meningitis is one of the commonest causes of infectious hydrocephalus in our settings. And on neuroradiology is characterized by basal enhancement that is shown, intense basal enhancement that is shown in the arrow. And there's also multiple infarct. As you can see, there's MCA territory infarct, head of coded nuclear infarct, as you can as seen on the CT scans in children that are presented in our center with post-infectious hydrocephalus. And often as well, some of these cases will present with tuberculomas or TB abscesses. This is a case of a 11-year-old child who presented with this tuberculous abscess in the posterior fossa, causing obstructive hydrocephalus that we had to go in and drain. Subsequently, this child ended up requiring a VP shunt, and this child demised a few months later because this child was just too ill towards the end because he had advanced disease and he was not responding as well to ARB treatment. As you know, the pathophysiology of TB meningitis is because of the hematogenous dissemination of the Mycobacterium tuberculosis and into the brain, where this granuloma will rupture. It's called the rich focus, and this bacterial inoculation of the subarachnoid space. And often 80%, up to 80% of patients with typical TB meningitis will present with hydrocephalus. And the infrequent involvement as well of the basal vessels, which is the medial straight and the thalamic perforating arteries, will result in ischemia, as shown as well in the previous slides, and complicate as well by elevation of ICP and cerebral edema. Often the area which is called the tubercular zone, that is area that is often affected as well by ischemia when patients presenting with TBM. CT scans may suggest communicating hydrocephalus in patients with TB meningitis. An encephalogram can distinguish between communicating and non-communicating types, influencing treatment strategies. We don't routinely perform encephalogram in our units, but I know some centers perform that. It'll be interesting as well to know from the audience how many of the neurosurgeons that treat TBM perform encephalograms in their units. This is important because you want to differentiate between either communicating or non-communicating TB meningitis, because in communicating TB meningitis, hydrocephalus medical therapy may be sufficient with multiple LPs, other TB drugs, steroids, while permanent CSF diversion is often always required for non-communicating hydrocephalus. And then your permanent CSF diversion strategies would either include the VP shunt or ETV. The culture of MTB from the CSF is considered to be the gold standard, but the rate of the positive culture varies between 6 to 54%. At our center, we're sitting at about 15% culture positive, but I think this can be improved, I think, in more centers as well. You can improve your diagnostic yield by increasing the amount of CSF. So we tend to send a lot of CSF, up to 50 mils of CSF volumes, so that we can increase the probability of culture, improve laboratory infrastructure and expertise as well from the lab. Molecular tests such as GeneXpect as well have been very crucial in offering rapid results, improved sensitivity and specificity. What you have to remember as well in treating this patient, that they got other comorbidities. They might not have only TB brain, TB meningitis, might have TB pneumonia shown in this kit that we treated with the chest X-ray, and also TB, abdominal TB. This patient has abdominal TB presented with ascites, which would make it difficult as well to treat this patient with a VP shunt. So you have to look at other alternative ways of CSF diversion, such as endoscopic procedures. So in one of the causes, often these patients with TB meningitis or TB hydrocephalus will present ill and will be critically ill and might need to be admitted in ICU because of raised ICP. You have to manage the raised ICP, and it's always better sometimes to manage it in ICU settings because they can have several infections, tuberculomas as well, the large mass lesions. They might have paradoxical reactions that can worsen their outcomes and treatment. Hyponatremia as well is one of the commonest complications of TB meningitis caused by issues such as SIDH, cerebral cell-voiding syndrome, drug resistant, because you might be dealing as well with multi-drug resistant TB, which can worsen the clinical conditions of the patient, necessitating them being managed in a critical care settings. And often, particularly as well in HIV positive patients, they can develop immune reconstitution syndrome, which can worsen their clinical picture. This often, the IRIS, which is the immune reconstitution syndrome, is caused if you start the patient on TB drugs and ARV in the same settings, and the patient reconstitutes their immune response by increasing their CD4 counts, that can result in a very intense immune response because of excessive and dysregulated host immune response, stimulating excessive pro-inflammatory cytokines. This is an example of an 8-year-old child who had these multiple tuberculomas, was studied on HIV positive, studied on ARVs and TB drugs, and developed this iris. You can see this tuberculomas have been large in size, and it's developed hydrocephalus, and these are multiple in size. So this necessitated, as well as draining some of these collections and then shunting this patient in the long term. And the scan, this scan that you see on your far right, shows after partial resolution of the tuberculomas, but the larger one had resolved by calcification, which is what we often see as well in tuberculomas with long-term anti-TB drug treatment. However, as you can see on the scan, there's multiple infarcts as well as the complications of TB meningitis, and this child had severe neurocognitive outcomes as well. In ICU, if these patients are managed in ICU and they are critically ill, usually they'll be managed with general measures, right? Head elevation, ensure airway protection, adequate oxygenation, respiratory support if it's needed, initiate anti-TB drugs, anti-inflammatory treatment as well, such as steroids, seizure management, because if they have seizures, particularly because with infarcts, they're prone to seizures, they might develop hypoxia while they're seizuring, which might further worsen cerebral edema. Hyponatremia, again, is quite an important challenge, and it has to be managed, because with hyponatremia, it causes a vicious cycle of cerebral edema, and the correct fluid management is quite critical, such as well ensuring that your hemoglobin is optimal, because there's global ischemia of the brain. So you need to improve your oxygen carrying capacity to the brain by improving your hemoglobin in the system. And then management of the hydrocephalus by a variety of procedures, procedures as mentioned previously, ranging from EVD, VP shunts, ETV, and often in patients that are in coma with a low GCS, you might have to put the EVD and then drain the CSF in a controlled fashion and treat the child aggressively with medical treatment, so that to kind of reverse the complication of TBM and improve as well the level of consciousness before you then proceed and for permanent CSF diversion. If you're looking at studies that have looked at comparing ETV versus VP shunts in children with TB hydrocephalus, in 48, the study from India looked at 48 children with TBM and showed that ETV was successful in 42%, while VP shunts in 54%. Another study, again from India, showed a success rate of ETV of 65.4% compared to 61.5% in patients with TBM. If you look at the wide literature, the ETV success ranges from 41 to 65.4%. And performing ETV, I think that has to be noted as well, can be challenging due to distortion of the anatomy of the third ventricle, thickened flow, and basal exudate. And some authors, I think this is what we have to critically highlight, is that you have to, some authors have also suggested that performing ETV during the chronic phase of ETV is quite, seems like a wise thing to do, because in order to enhance the prospect of the success of your ETV, to avoid the challenges that I've alluded to before. It's an example of a child. You can see this intense basal enhancement. You can see the thickening of the flow of the third ventricle. This child had TB meningitis, hydrocephalus, and this is the intraoperative picture. As you can see, in a child like this, look at this MRI, look at the intraoperative picture. It's very difficult to perform an ETV. The anatomy is distorted. You don't know where your basilar artery is. There's a lot of tubercles as well in the flow of the third ventricle, which makes the procedure very unsafe. Looking at our experience as well, particularly in children that are also immunocompromised with HIV and TB, often they'll present with the BMRC grade 3 grading system, and often most of them, we found that 61% of them are on ART, but this number has improved over the years with easy access of ARVs. What we found to be related to mortality, which signifies a step towards mortality, was if they present with multiple infarcts, if they've got extra meningeal TB, such as TB meningitis, TB pneumonia, that increases your risk of mortality, and if they develop shunt complications, right? CD4 count as well matters in children with a lower CD4 count and those with hyponatremia. So hyponatremia increases your risk of immortality in children that have TB meningitis-related hydrocephalus. In our setting as well, we'll see cryptococcal meningitis, which is caused by cryptococcal neoformans. This is often an age-defining illness, with more than 75% of cases reported in sub-Saharan Africa, with a high mortality rate. It's uncommon though in children, even in sub-Saharan Africa, with incidence ranging from 0.85 to 2.9%. This is diagnosed by culture. If you culture cryptococcal neoformans on CSF microscopy, cryptococcal antigen detection, or if you culture it on PCR. This is some of the cases that we've treated over the years. If you see often as well, these patients will present with blind because they've got intense raised ICP, and often as well the ventricles, because the cryptococcal neoformans, the fungi will coat the ventricles, making them stiff. So these ventricles tend not to expand as in other forms of hydrocephalus. And often, sometimes children might present with normal-looking ventricles, but when you do an LP, the pressures are quite high. Hence, they present with visual deficits. And initially, the treatment will be to treat these patients with antifungal therapy, where it's divided into an induction phase for 2 weeks, consolidation phase, then you move on to consolidation phase for 8 weeks, and the maintenance phase, which might go on for more than a year or even lifelong, And then the patients are also started on ARVs if they're not on ARVs, and one has to be careful as well, not to develop as well an immune response if you start treatment in ARVs at the same time. Often, then these cases as well can be managed with LPs to try and bring down the pressure to about 50% of the initial pressure, but if over a period of about 10 days to 2 weeks. But if then the pressures remain very high, the patients have severe neurological deficits or deteriorating, particularly with threatened vision, then we'll proceed into shunting these patients. Those with the smaller ventricles as well, the use of navigation has been quite helpful in these instances. So for me, the take-home message when you look at post-infectious hydrocephalus is that PIH is the predominant infection is the predominant cause of hydrocephalus in sub-Saharan Africa. These are the infections as well affect the quality of life, because often these patients will present with multiple infarcts, resulting in cognitive deficits, resulting in learning difficulties, in children. Prevention is key, because infection, so access to early healthcare services, especially during delivery, is key. Early treatment and diagnosis is key as well to prevent complications of hydrocephalus. Comorbidities, one have to understand that when you're dealing with patients with post-infectious hydrocephalus as well, they could have infections in other systems of the body, so they will have comorbidities, which will increase the likelihood of complications and even mortality. And this is a socio-economic status problem. And I think with improved healthcare and the socio-economic status of countries, I think we should see the incidence of post-infectious hydrocephalus decreasing. Vaccination plays a very important role, I think, as I've alluded to previously. The vaccinations against TB, vaccinations, neonatal vaccinations help decrease the incidence of meningitis. It's quite important to offer tailored antibiotic therapy that is based on culture and sensitivity, and tailored CSF divergent procedures, which range from EVD, VP shunts, ETV, CPCs, endoscopic lavage, depending on what on the pathology or the condition of the patient. And one have to know that the post-operative complications are quite high, particularly shunt infections, because if you got previous infections, that increases your probability of shunt complications and blockages because of the debris that can remain in the ventricles. And these patients will require long-term follow-up because of neurocognitive deficits and because of increased risk of infection. So it's not one of those patients that you just treat and then you never see at your clinic, just expect that they will come back, especially if they develop multiloculated hydrocephalus. Looking forward to seeing everybody at the 52nd annual meeting in Egypt this year. I know it's going to be a good meeting. Looking forward to it. And I'd like to take this opportunity to thank everybody for listening to my talk. I know it's Sunday evening, but we appreciate the audience. Thank you so much.
Yeah, thanks, Bez. It was a real masterclass. So thanks so much for touching on so many important points. So we've run a little bit over, not a little bit, we're 10 minutes over time. That's 2 hours on a Sunday. And I think the fact that we've managed to retain that strong an audience, John, just speaks to the quality of the speakers and really kind of the presence of, you know, African pediatric neurosurgery perspective on this disease. Just to, in fairness, I'm going to give everyone 10 seconds just to make a comment and just a final closing remarks. So Nels, I'm going to start off with you. Anything you want to say? Just kind of 10 seconds to close off.
Thank you very much. Congratulations for the very high level of this webinar. Excellent speech, Basil. Congratulations for your work. And hope we can see you again soon.
Thanks, Nels. Thanks. Ted?
We have more time, Llewellyn, if you want to use more time.
Yeah. No, thanks, John. We're also very cognizant of people's time. So we'll wrap up and then we'll have some closing comments. Thanks, John.
Yes, I mean, it's been a good time. I've really learned a lot. Basil has been amazing in terms of the material that he covered. Looking forward to more of these sessions to improve our expertise on the continent. Thank you very much.
Yeah, thanks, Ebenezer.
Thank you very much, Llewellyn, for the invitation. It had been a great honor to listen and learn from all experienced surgeons, and I have seen some of our colleagues and residents who were also attending, and it's a great session. Thank you very much.
Okay. James, you still on, James? Yeah, James.
Are you going to do another presentation, Llewellyn, or you want to just open it up for a question?
We'll open it up for a quick discussion. Thanks, John. I just want James to make a comment. And then we can...
All right, so thank you, everyone, and thank you, Marcel, for this presentation. Obviously, also thank Tazid. I think we've had a wonderful session this evening. Hydrocephalus, for me, I mean, there would always be discussions. If you open up the discussion right now, it's probably going to end up another hour or so. Because, I mean, from the last two presentations, there are questions in my mind, the things to ask. What exactly, I mean, for example, for the post-myelomeningocele repair, especially when you have a postnatal repair, the question always is, when do you know if your ETV fails compared to if you insert a ventricular peritoneal shunt? The question is from, obviously, the pathophysiology of myelomeningocele-related hydrocephalus is a completely different game. And sometimes these kids would usually adapt, and over time, some of them also develop syrinx, okay, because of the adaptation and all that. So the question is always the long-term CPC, ETV plus CPC in the long term versus ventricular peritoneal shunt. But like I said, I think this is opening up a lot of stuff for discussion for not just residents, even for staff neurosurgeons who also don't have a lot of workload in terms of pediatric neurosurgery, and those who also are very familiar with some of these cases. It just comes in as some course, some kind of refresher courses. And I want to thank the faculty a lot. Thank you, Llewellyn, for making this happen. Obviously, Mohammed is in the operating room, and so we hope that the next time we would have him here with us, and then we can have much more perspectives. And I think Professor Figen has been on the call for a while now, I think. So maybe it would also be nice to have him speak. Thank you.
Okay. Thanks, James. I did ask Graham before. I don't know if he's still on. It would be nice to get some comments if he's still on.
Yeah, Llewellyn, I'm here. Thanks, James. So firstly, well done. Sure, that really was a spectacular 2 hours. And as James says, we could spend at least another hour talking about all the issues raised. I guess just a couple of reflections, one of which is even if we don't fully understand CSF physiology, we've clearly got a an increasing array of treatment options. But for me, certainly it comes down to trying to get it right the first time. And I think it's really important if the first time you intervene in treating hydrocephalus to try to get it right. And if you do, then you really got to do the patient a favor. But I want to pick up on the word that Teddy used when he spoke about not having a unimodal approach. And I think something else that came through all the talks today was just how important it is that we work with colleagues beyond neurosurgery to not just extend the range of treatments we offer, but also to make sure that the kids get diagnosed earlier and think about the sort of primary healthcare aspects where we want to get these patients to us earlier so we can treat them properly. But sure, well done, Llewellyn. Well done, Mohammed. It's just a fantastic session. Loved all the talks. So thank you to all of you. Thanks. Bye.
Thanks so much, Graham. It's really great to get that perspective, just kind of weaving all the talks together, and a tremendous amount of experience, Graham. Thanks so much. Any other comments, John, that we have? I don't think I've missed.
Yeah, I think there's a couple more.
Okay.
Go ahead. People are waiting to ask a question. Miriam, do you have that question you want to ask? From Teddy? Are you there, Miriam? Perhaps not.
No.
Perhaps not. Anybody else want to comment before we close? Last chance. Okay, I guess well, that's the most participants we've had all year. And I think the key is your organization. You brought all these panelists, and I think what the panelists did is they brought some of their followers. That was the key to today's success, in my opinion. And we look forward to having more. I'd like to do it once a month, but whatever you think, you'll be communicating with me. Okay?
No, absolutely, John. Thanks so much. You and I will chat, but we were looking at once every 2 months. But James is very keen. I know he's more keen than everyone else, James, to do them on a monthly basis. Hey, James.
Well, it's up to you. It's up to you. So we'll
Okay,
be here. We'll be here.
We'll feedback to you, John. Okay. Again, thank you so much. Can't thank you enough. And one other thing, like you said, I think of all the participants, more than half, about 60% were African participants. A lot from South Africa, Nigeria, Ethiopia, and Ghana. So really, I think your point about panelists just disseminating the word within the organization really made a difference.
Yeah,
Okay.
there's a need. Let's fill it. Okay. Thanks, everybody, for participating. Bye-bye.
Thank you. Bye-bye. See you.
Thank you. Bye-bye.
Thank you.
Okay, stop the recording. And I